Society. Thank you, Dr. Kruger, for really the privilege of speaking with all of you. It really is a blessing to work with all of you and talk about uveitis. And so when I think about uveitis as a discipline, I've learned more and more that each patient that we meet, it really is part of their journey, part of their uveitis journey, and it can be very complicated. It can be very stressful. And so we want to think about the latest and greatest technologies that we need to treat their condition, whether it's coming from an autoimmune perspective or a systemic perspective. So I'll be speaking to some of the innovations in the diagnosis and management of uveitis, and we'll just go ahead and just jump right in. So in the way of objectives, first I'll talk about some of our approaches to uveitis classification and recent innovations with related to these classification systems for the diagnosis of uveitis. I'll provide an overview of the diagnostic and therapeutic options for the medical and the surgical management of uveitis, particularly related to some of the emerging infectious diseases that our group and others have studied, and also we'll review some of the recent clinical trials that impact evidence basis for the medical management of non-infectious uveitis. So it's really important as we think about uveitis syndromes that we really avoid the perils. There are multiple uveitis syndromes that can have immediate vision-threatening consequences if they're not recognized and treated, and there are also many of them that have systemic and public health significance. With infectious uveitis, herpetic retinitis can be a very aggressive disease that can lead to rapidly progressive vision loss, such as these cases of acute retinal necrosis. Birdshot retinal choroidopathy can present in very protean manifestations. I often see patients who present just with floaters that actually have these very discrete lesions that can be difficult to see. And ultimately, other patients, patients who are over 50, that's a risk factor. Sorry about this again, can have vitreoretinal lymphoma and ultimately develop central nervous system lymphoma that again can be life-threatening. But much of what we do is based on pattern recognition in ophthalmology, whether we're thinking about complex keratitis or uveitis. We think about the patterns also in the context of the patient history. So I'll just show you a few pictures as you sort of rewind your mental Rolodex of diagnoses that you remember from your BCSE books. The first patient on your left-hand side is a patient who's HIV positive on antiretroviral therapy, compliant with medications. You see these well-demarcated plaques within the posterior pole. Then in the middle, you have a patient HIV positive off of antiretroviral therapy. We don't see this case very often anymore. CD4 count is unknown, but actually then was known to be less than 50. You see this yellowish material, brush fire retinitis. And there's another patient who has a history of varicella-zoster virus, V1 shingles, and decreased vision. And so any brave souls want to tell me what's this diagnosis in the middle? I heard CMV retinitis, so absolutely right. So you got CMV retinitis in the center. You've got syphilitic retinitis. It's growing in terms of the disease prevalence, not only within the United States, but around the world, and also a case of acute retinal necrosis, varicella-zoster virus retinitis. Again, looking at these distinct patterns, also in the context of the specific patient scenario. And so this is really the basis for how we think about laboratory testing. And how do we approach the diagnosis of these patients? First, we want to approach it from the standpoint of identifying the anatomic location of the uveitis, classifying whether this is anterior, intermediate, posterior, or panuveitis. So we're all speaking the same language. We have complications such as synechiae, cataract, cystoid macular edema. You have an anatomic diagnosis that really predicts what our differential diagnosis is, followed by thinking about the structural sequelae that is leading to vision loss. We ultimately want to make sure that we rule out infection with a distinct workup specifically to look for syphilis, TB testing. In select clinical scenarios, we'll also look for viral retinitis and viral uveitis with PCR testing. And I'll talk a little bit about metagenomics, which is also increasingly important from a research perspective. And there are also radiographic tests and consultations that we'll need because of the systemic nature of disease entities that we ultimately treat. And so I'm just going to give this is a high-level overview. I know that we have a number of students and residents, some fellows in the audience. And so as we think about this, first we think about classification, infectious versus non-infectious uveitis. Very important to make sure that we don't think that we're treating an infectious uveitis with corticosteroids alone. Some of the key players include toxoplasmosis. This is the leading cause of infectious uveitis globally. TB certainly has a public health significance. When we think about systemic versus ocular disease, these can have autoimmune implications both systemically, such as sarcoidosis. Some of these patients will have cardiac manifestations, pulmonary manifestations, or ocular autoimmunity can be seen in isolation, such as with birdshot retinal choroidopathy, A29 positive patients with night vision abnormalities, peripheral visual field abnormalities, and sometimes cystoid macular edema, and thinking about anatomic locations, anterior, intermediate, posterior, and pan-uveitis. Again, very important for classification. Classic hypopyon that we see with B27-associated uveitis, Behçet's disease, and endophthalmitis as well. And there are grading schemes that have been used. This is the SUN criteria. This is a standardization of uveitis nomenclature with objective criteria by slit lamp examination, also fundus photography on a grade from 0 to 4+. There's actually another scale that's been developed by Janet Davis out of Bascom Palmer, but you can pick whichever grade you want to use, but it's important, again, from an objective quantification perspective as well as for research purposes. There was a movement actually in the late 2010s, early 2020s to actually look to classify 25 of the most common uveitis syndrome. This is out of the standardization of uveitis nomenclature working group, or the SUN working group, where a number of centers actually pooled patients from multiple centers around the United States. Ultimately, there were 4,000 cases that achieved supermajority for conditions such as VKH, HLA-B27, Behçet's disease, and there were a number of papers that were published on this topic. Ultimately, the goal was to classify these disease entities using artificial intelligence and machine learning. These cases were split into a validation set, a training set as well as a validation set, and ultimately showed that machine learning algorithms were able to correctly predict the disease, 94 to 99% accuracy for these uveitis syndromes, and there's a number of papers that have been published in the American Journal of Ophthalmology. Very important also to use ophthalmic imaging to objectively follow patients. We're continuing to use fundus autofluorescence, especially with regards to outer retinal pathologies, conditions like serpiginous choroidopathy, and acute zonal occult outer retinopathy, and others as well. And certainly OCT is growing relevance. It really is one of our vital signs now in the uveitis and the retina clinic. This was an interesting patient that really brought together some of these principles. This is a 30-year-old female patient presented with acute hypertensive anterior uveitis and actually had a thalamic stroke 2 days after presentation, so very severe systemic illness. As you can see that she has these spotty areas of transillumination defects. She had elevated intraocular pressure, and her aqueous humor was ultimately positive for varicella-zoster virus. And this really brought together the symptoms of her thalamic stroke. She actually had a CNS vasculitis. And this was interesting because the PCR from the aqueous humor was positive, but the CSF actually turned out that they weren't able to identify VZV. But she was ultimately treated with a combination of valacyclovir and topical corticosteroids and had a full neurologic recovery. So we actually can play a role in the treatment of patients from a systemic perspective as well. Again, thinking about the eye as part of a larger system that can be affected by both infection and autoimmunity. Now, switching gears a little bit as we think about infectious uveitis and infectious eye disease from a global perspective. And I think one of the things that I've really appreciated about just seeing the speakers from this conference, really this sense of global mission, is that people are working all over the world to care for patients and really show God's love through the care of patients with complex conditions. I've talked about syphilis and TB, toxoplasmosis, but ultimately there are other emerging infectious diseases such as Ebola, which our group has and our group and others have studied, as well as Mpox, which have had either ongoing outbreaks, and I'll mention that a little bit more with Ebola, and Mpox, which actually also is of global health significance. And the University of Nebraska was recently involved in the hantavirus response with regards to the cruise passengers who were potentially exposed to hantavirus. And these emerging infectious diseases are consistently on and off the radar. Most recently, this is a report from June 2026 in the news that the United States is actually moving over $1 billion to support the Ebola response within the Democratic Republic of Congo. I just had a really nice conversation from our kind colleagues from Samaritan's Purse talking about their tremendous response to address this growing burden of disease and the importance of care in Eastern DRC. But I'll submit to you that the eye really represents a unique window to these emerging infections. This is a patient, a United States healthcare worker that we took care of, who developed a severe sight-threatening pan-uveitis after he had survived Ebola. This is another patient from our colleagues from UCSF who characterized mpox actually within the aqueous humor as well as within the cornea in the context of mpox as well. And our colleagues from the CDC recently characterized conjunctivitis in dairy cattle workers, as well as, and there's actually other reports with birds who have conjunctivitis as well. This really brings together both human and animal disease related to highly pathogenic avian influenza. And very important, as you see these links with regards to how these can ultimately lead to eye disease and importance of awareness from our perspective as well. And this is the healthcare worker that we took care of. What I wanted to mention is that this was actually rapidly progressive in about a 2-week period. The patient actually developed severe pan-uveitis. We ultimately identified Ebola virus within his aqueous humor 3 months out after he had survived this acute, life-threatening infection. And the reason why this matters is we think about the work that we do in the United States, and ultimately some of this also applies to individuals who we care for overseas as well. This young girl, her name is Aminata Kanta. You can see that she is an Ebola survivor and has developed this posterior sneak eye with this dense cataract. This was a photograph from a New York Times reporter who traveled with us to Sierra Leone back nearly 10 years ago now. But we've had the ability to take care of, the privilege of taking care of Aminata, as well as watching her grow up in this context. And so, as you can see, that uveitis can affect patients both within the United States and globally. Important to have these on the radar. Our colleagues from the NIH looked at this population of patients in a bigger way with nearly 1,000 Ebola survivors who were evaluated. Over 25% had evidence of uveitis. And we also found that the reasons why patients went blind from uveitis really had to do with health access, some of the complications that we see from untreated uveitis, including posterior sneaky eye, cataract, neovascular glaucoma, unfortunately, ptysis in some patients as well. But I wanted to draw your attention to the ongoing Bundibugyo Ebola outbreak in DRC, which is again of growing global health concern. In mid-May this past year, just a couple months ago, the Bundibugyo outbreak was declared. It was subsequently declared a public health emergency several days later. We have a number of individuals who have been very involved with U.S. healthcare workers, including Dr. John Cropsey and again, Samaritan's Purse. But ultimately, thus far, over 2,500 cases, and actually, I really can't keep up with the updates, but it actually exceeds 3,400 cases right now in the DRC, and it actually is the largest outbreak of Ebola in DRC to date. This is dating back from 1976, and so the trajectory is very concerning. And because of what we know about eye disease with Ebola survivors, this is something that we certainly have on the radar. So we need not only the care, but we also need the tools to continue to characterize this disease. Now, what are some of the tools that we need to think about, and how does this apply to what's going on locally as well? Well, I wanted to draw your attention to a technique. It's not a new technique, but it's a technique that we've been continuing to study with our collaborators from the UCSF Proctor Foundation and others. And this is metagenomic deep sequencing. This is being used not only for uveitis, but also for keratitis as well. This is an unbiased approach to pathogen detection through high throughput parallel sequencing. Its capabilities include pathogen detection and lineage tracing. Essentially, what this technology involves is amplification of the DNA and RNA from a sample of interest, subsequently subtracting out the human DNA, and with the amplification of these non-human pathogens, you can actually identify which pathogen is disease-associated and sometimes disease-causative. This is a 40-year-old man with a history of uveitis for over 2 decades. And interestingly, metagenomics showed that rubella virus was in this patient's eye. And when they looked at the phylogenetic tracing, again, lineage tracing, they showed on this phylogenetic tree that this sample from UCSF actually traced back to a strain of Ebola virus that was circulating in Germany around the time that uveitis first developed. So it really is remarkable as we think about viral persistence, how a virus may persist for a long time longer than perhaps than we previously understood, and we're continuing to understand this further. This is another patient I saw, a 59-year-old patient with hearing loss, referred for bilateral anterior uveitis for 10 years, inferior keratotic precipitates. You can see the iris heterochromia with its iris thinning in the right eye compared to the left eye, and ultimately was identified to have rubella virus in the aqueous humor as well. There's also PCR testing that's available. One of the things that I review pretty consistent with our residents and fellows is what is our general approach to diagnostic vitrectomy, testing and considerations. Coming back to our initial photographs that I showed you, this really relies on pre-test probability. If we're thinking that this is a viral entity, then our first sample we're likely using quantitative and qualitative PCR. Also important to send off for cytology and flow cytometry, both from a care, and there are also sometimes medical legal implications. And this goes on as we think about bacterial and lymphoma, always using your highest yield specimen for the most likely diagnosis. And shifting gears to uveitis masquerade syndromes, primary vitreoretinal lymphoma is a high-grade B-cell lymphoma. This is patients sometimes have a history of central nervous system lymphoma, age greater than 50, maybe insidious in onset with floaters, decreased vision. You can see some of the phenotypes here with both vitritis, subretinal infiltrates as well. And there are a variety of tests that are utilized as well, including metagenomics as well as cytopathology, cytopathology being the continued gold standard. And as I mentioned before, there are a number of different phenotypes, including subretinal lesions. May be difficult to see, but this patient has multifocal retinal infiltrates. This is in the setting of vitreoretinal lymphoma recurrence. This patient had almost a retinitis-like appearance and also a history of abdominal lymphoma as well. This is a case of a very nice lady that I took care of who didn't have a diagnosis before she came to see us. And actually, after some time, we still didn't have a diagnosis after she started seeing us. But she had subretinal lesions in her right eye. We actually had performed a vitrectomy in the left eye, but there was no evidence of lymphoma in the vitreous in the left eye at our initial testing in our initial surgery. So we decided that what we wanted to do was, let's see, Hunter, would you mind just queuing that up? We wanted to go ahead and actually biopsy the subretinal space. And with the advent and advances in microincisional surgery, we're able to access both the vitreous cavity and the subretinal space. What I like to do to access the subretinal space is to make a small retinotomy, similar to what we do for retinal detachment surgery. And this is actually the fellow going into the subretinal space with a soft tip cannula. I like to sit in the assistant seat and also aspirate very gently as the fellow is going into the subretinal space, because you can actually segregate the vitreous from the subretinal compartment, because there are immunologic differences between the vitreous and the subretinal space. And you can see that the aspirates are going into a 3 cc or a 5 cc syringe. And Hunter, can you just fast forward maybe about 20 seconds or so with the video? Thanks for scrubbing that. And then it's very tempting to take all of the precipitates. It's actually a very satisfying procedure. And the retina is very pliable, as you can see, but you don't need to get all of them. You just need to get just enough to have enough cells for cytopathologic evaluation. And after we get the biopsy, we go to air, put in a gas bubble, and endo laser. And what was remarkable was that the subretinal space was indeed positive for lymphoma, but the vitreous actually tested negative for lymphoma. So it turns out that we think that some of the vitreous cells may actually be an inflammatory response to the lymphoma within the subretinal space. And for the last few minutes, I just wanted to touch on some of the key clinical trials, specifically with a focus on local corticosteroids and local therapeutics for non-infectious uveitis. Some of the leading studies include the multicenter uveitis steroid treatment study, where this was a comparison of systemic immunosuppression versus local long-acting corticosteroid. We have one of the leaders in this for the study in this group, Dr. Kempen, who's in the audience today, but really helped us define the comparability and the efficacy of systemic immunosuppression for the treatment of non-infectious uveitis. Adalimumab, also known as, Humira is one of the names of the drug, but again, there are a number of biosimilars that are available There was a study, Visual 1 and Visual 2, that showed its efficacy for active and inactive uveitis and is FDA approved, and so you'll see that quite a bit in clinical practice. And there's another study from out of the Proctor Foundation looking at anti-metabolites, comparing methotrexate and mycophenolate mofetil, showing that there's comparable efficacy with these anti-metabolites for uveitis as well. But I really wanted to focus on local corticosteroid delivery. We're fortunate that we have a number of phase 3 or multi-center studies for local corticosteroids, including the dexamethasone or the Ozurdex implant. There's a POINT trial. This is an NEI-funded trial that looked at intravitreal versus periocular corticosteroids, demonstrating the efficacy and suprachoroidal drug delivery, which our group and others have worked on previously as well. And I'll talk a little bit more about those medications. Retisert, the fluocinolone acetonide implant, this is the long-acting 3-year implant, was actually discontinued, so we no longer have that in our armamentarium for uveitis. But if you're going to look at one paper related to corticosteroid therapies for uveitis that really summarizes a lot of the studies, this is a report out of the American Academy of Ophthalmology from my colleague, Dr. Justine Smith. They looked at over 700 citations and over 20 articles with level 1 or 2 evidence related to periocular, suprachoroidal, and intravitreal corticosteroids. And these reports consistently showed that local corticosteroids improved visual acuity, macular edema by OCT, or both measures. And one comparative study showed, this is again the POINT study, showed that intravitreal Ozurdex and triamcinolone acetonide actually performed better than periocular corticosteroids or subtenon's Kenalog for the treatment of macular edema. Always need to make sure that we remember that elevated IOP and cataract can be of concern. This is a report from the NEI-funded study that showed that there was a reduction in central subfield thickness with both intravitreal and periocular corticosteroids, with a greater reduction with intravitreal corticosteroids. This is a suprachoroidal technology where medication is being instilled into this potential suprachoroidal space with the goal of having higher levels of drug within the retina and the choroid versus the lens anterior segment, with the potential for reduced IOP elevation. I like to use subconjunctival lidocaine for this injection, and I ensure that because this is a microneedle, we want to make sure that we leverage the entire length of this tiny needle to enter the suprachoroidal space. So I ensure that this is perpendicular to the surface. There are 2 needle lengths, and this is a very nuanced technique that requires some training, but can be very effective as demonstrated by this phase 3 data that showed that there was about a 2 to 3 line visual acuity improvement with suprachoroidal corticosteroid for the treatment of macular edema due to non-infectious uveitis with favorable intraocular pressure outcomes. And the last concept that I wanted to mention that I think is really exciting from the standpoint of just moving ahead with personalized therapy for non-infectious uveitis is the role of interleukin-6. Interleukin-6 has long been studied in both animal models and also in some limited patient studies to show be a key player related to a number of inflammatory conditions, including both Behçet's disease, VKH, and also sarcoidosis, which we see commonly in clinical practice. And there was one systemic IV study where they looked at IL-6 inhibition. This is tocilizumab from our colleague Dr. Quan Nguyen, which showed that patients who were treated with IL-6 inhibitor actually demonstrated a reduction of cystoid macular edema and inflammatory metrics. And more recently, there have been studies looking at intravitreal IL-6 inhibition. There were the phase 3 MEERKAT and SANDCAT studies that showed favorable results with visual acuity improvement and reduction of macular edema by OCT. And so we're excited to see how this program moves forward in the future for the benefit of patients with non-infectious uveitis. Again, this monoclonal antibody actually inhibits specifically interleukin-6, which is a key inflammatory mediator in non-infectious uveitis. And so I've covered a lot of ground, but what I would say is that there are exciting innovations in uveitis, including imaging, artificial intelligence. We've talked about metagenomics, but ultimately we need these tools to treat complex disease, whether these are patients within the United States or within a global health or resource-limited settings, because this is, again, part of the uveitis journey for individual patients. There are a number of clinical trials that, again, support the efficacy of these local therapies, as well as systemic therapies, particularly for non-infectious uveitis. So again, I'm happy to answer any questions. Again, thank you, Dr. Kruger, for the opportunity to speak with you, as well as everybody else from COS. Thank you.
Okay. Okay, thank you, Steve. That was great. Quick questions from the audience. I mean, this is the kind of stuff that we routinely don't see in our practices, and yet it's out there, and it's good to know that there are people who are tackling these issues like you are. Jeff?
Fantastic talk, Steve.
Yeah, thanks, Jeff.
So with that number of survivors now with that number of survivors of the outbreak in the Congo, and I think there's a huge lack of ophthalmologists in Congo. We have the mighty Cropsey nearby in Rwanda, but I mean, is there any sort of thought or plan if it's really 26% going to looking at sequelae? I mean, what would be the plan or the idea, and how would you be treating that?
Yeah, no, I mean, Jeff, amazing question. I think that individuals like yourself who have done, incredible projects at scale will be well positioned to continue this conversation. I think that, again, a big concern is the very high percentage of patients who are at risk. And we don't know whether the Bundibugyo strain behaves like Zaire, where we do see these percentages. With regards to thinking about infrastructure within Congo, currently, one of our colleagues, Dr. J.C. Mwanza out of North Carolina, he's very well connected. He's, again, Congolese by descent. And so we've been in conversations with the other COS. This is the Congolese Ophthalmology Society. And it turns out that there's about 150 ophthalmologists within Congo. Within that region, there's very few. And it's challenged not only from an infrastructure perspective, but also a security perspective, because there are militia groups that are in that region. So I think that it's sort of, I would say, two or threefold. But one would be ensuring that there's health security and really just personal security for any individuals, including Samaritan's Purse, other large groups that are out there, but also the infrastructure. But I think that having that local capacity and strengthening are really key. We're in some conversations related to webinars and instructional things, but I think having that on-ground capacity is important not only for the acute response, but for the long-term response. Because as the numbers sort of rise, the outbreak from 2018 to 2020 had about 3,200 cases, and it was a 2-year outbreak. This outbreak is already at 3,500, and so we're already looking at a long-term engagement. So I think it's going to be, hard to predict the future, but it seems like a long engagement where we're moving forward with different infrastructural needs, training, and healthcare capacity are all needed with the infection risk involved.
With the outbreak numbers where they are, is there a chance that this could actually still spread to around the rest of the world?
Yeah, I think that the other thing about Eastern DRC, and this is something that is talked about some in the media, but this area actually is a very, very busy area with a lot of economic movement. There have been I think around 20 cases in Uganda already. I think that all of the areas all the countries in the region, Rwanda, Sudan, Uganda have all sort of tightened their borders. But ultimately, there's a lot of movement. We're watching Kinshasa very closely. So I think that there's always that concern. There was that one healthcare worker who unfortunately developed a virus on his way on a plane back to France. Not to say that we need to be scared, but at the same time just to be aware, and also just that it needs the proper response. And I think that groups like SP, Surge, and others are really very involved.
Okay. Any other quick questions? John.
So we had a small Marburg virus outbreak in southern Ethiopia, in the last year, and I was just wondering if Marburg would end up having a similar pattern with uveitis, and probably there's a whole wide class of viruses that might have really high uveitis incidence. So what are your predictions about that?
Yeah, so great question, John. And you're absolutely right. Marburg has come up in Ethiopia, Kenya, obviously, other countries as well. And so I think that in the late 70s and early 80s, there were just rare cases of uveitis with virus identified. And so I think in these patients, I think that there's a likelihood. I don't know exactly what the percentages would be, but I think in Rwanda there were also cases, a few years ago as well. But I think it's something that needs to be investigated, and I think it's also important for individuals, especially who are working in those settings, to be at least have it on the radar with regard to an infection control perspective. That again, very important consideration for patients and for safety.
Yeah, it might be
Yeah, very remote, right?
Okay.
Okay, great.
Thank you
All right,
very
thanks, Ron. Okay, thanks. Oh, thank you.